So hello, we are back on the Chris TV. This is the first day on Chris 2024 conference, and we are having a great day today. And I'm your host, Dr. Abad Khan. I'm an interventional cardiologist practicing in Ghaziabad. And with me, I have a very special guest and esteemed faculty, Dr. Colm Hanratty. He's the director of a cardiac Cath lab in Meta Private Network, Dublin, Ireland. Welcome to Chris TV. And just a short engagement. How are you?
I'm good. It's my first time in India, so I'm really enjoying it.
Yeah, really enjoying it. Great. That is superb to hear. There were consistent small breakthroughs in calcium modification since last 30 years. But all the strategies of either root ablation or metal atherectomy usage, they did not pick up as good as since the IVL approval and the breakthrough happened in coronaries. But since the use of IVL has increased so much for this calcium modification, and as the technology has also upgraded pretty rapidly now, we have seen the C2 Plus also. So from now where we are today, what do you see the scope of IVL being in the future?
Well, I think there's a deeper conversation about how do we manage calcium and how are we managing calcium in 2024. And the first thing to say is that intracoronary imaging is critical in trying to understand the patterns of the calcium. So we now understand that there's different types of calcium. There's eccentric calcium, concentric calcium, and calcium nodules. So to say that there's one technology which fits all is not correct. You're right that there's been different technologies down the years which have failed to solve all the scenarios. And IVL has been very, very useful. It's been a game changer in terms of managing certain types of calcium.
Okay, so I believe that IVL is absolutely a game changer, but one strategy fits all still is not possible right now. We are seeing that a fast wave laser based system which has been developed for the lithotripsy, which is potentially, by theoretical standards, it has a potential to be a game changer. It will be easier to cross the lesion because of the low profile. It will be delivering fast pulses, the nerve pulses, because the balloon uptime will be less. So in tricky anatomical scenarios like a distal left main scenario or an ostial left main scenario, where putting up balloons for a longer time is really difficult. What are the expectations for this laser-based lithotripsy which is being developed?
So I'm not an expert. I like all these technologies. It's only whenever you get into the human coronary arteries that you can tell what's going on. Laser has been around for 25, 30 years?
Yes.
So if laser worked in calcification, you work on a standard wire, you've got to cross the lesion. Why are we not doing more laser in coronary calcification? So why were you not taught to use laser in terms of calcification? And I think the reason for that is laser is of limited value in terms of calcification. Now, it can certainly modify the tissue around the calcium to help with the compliance of the vessel, but it does not actually. So I remain, while I'm at the forefront of these technologies, I am not as early an adopter as some might think. I like to see how equipment behaves in the coronary circulation before I form an opinion, because what happens in a bench, even if it's very, very exciting, whenever you get into the coronary situation and a very hostile anatomy, that's whenever you see how devices develop. So I'm not trying to put cool water on any technology. Any development we have is great, but I like to wait and see.
So he believes that waiting for that data to come and having a great data and then putting these technologies to work on the patients works supremely well and works for him as well.
So to expand on that, what I mean is how does it help me in the lab deal with the patient? So the data is of good value for sure, but it's really whenever you get it into your own hands, in your lab, in your setup. So a lot of people, we just had a discussion in terms of different technologies, and because they do well in a clinical trial in expert centres does not mean to say that will be translated across the board. So I like to reserve the judgment until I get the equipment.
Perfect. That is actually how it is to be done and how everybody does it. Giving a talk and experimenting on patients at home does not work. Also, just continuing on the calcium modification, as the burden of the de novo calcium diseases has increased significantly, maybe because of increasing bias and reporting, also due to increased imaging usage lately. With the expansion of the treatment options of calcium modification, one disease has come on, the disease of an underexpanded stent. So difficult to treat subset. How do you see this changing over the current available devices with imaging as well as calcium modification? The disease of underexpanded stents.
Yeah, well, I think what you're talking about is stent failure.
Yes.
So why do stents fail? Stents are manufactured predominantly in Ireland, where I'm from, in Galway, with Boston, Medtronic, and with Abbott and Clonmel. When they leave the factory in Ireland, they're in pretty good shape. Whenever they fail in a coronary artery 6 months later, it's not the fault of the engineers manufacturing, it's the fault of the doctor implanting them.
Yes.
What we've got coming down the line is an older, sicker, comorbid population for whom cardiac surgery is not an option. There's more and more calcified disease. I take your point about the imaging, that we're picking up more of it, but also there is more of it because the cohort of people we are dealing with are much sicker. And one thing is for sure, that if you put a stent in without modifying calcium, and let's be honest, calcium is a big reason why stents do not fully expand. They do badly. So if you look at any of the subsets, let's say for example Noble, and if you look at the imaging group of Noble, the group that did the least well were the ones that had underexpanded stent because of the presence of calcification. What we have to do as doctors, as clinicians, is to, number one, identify the calcium, and number two, modify it. And the last thing we should do is put in stents without modifying it. One thing is for sure is that if you identify the calcium after you put your stent in, then the management of that is very difficult. So IVL that we've talked about, which is a game changer technology, does not work as well whenever you have a stent in. To take rotational atherectomy and have to drill out that stent to modify the calcium, that's no fun for anyone. So if you put stents in without modifying calcium, you're really subjecting your patient to a bad outcome.
So, and then the gist of it is preventing the disease of underexpanded stents is the best way out actually. And sir, how's the experience have been on the first day of the CRISP 2024?
Very good, very exciting meeting, really enjoying the interaction. We had a very good discussion there in terms of calcium modification, very good discussion. So I think it's a fantastic meeting, really enjoying being in Mumbai. And it's a bit warmer than Ireland currently, so I'm having a good time so far.
That's great. And I'll be asking you a few rapid fire questions. You can choose to answer however you wish. So very joyful, teaching, working or traveling?
Teaching.
Great. Very fun, coronaries or structural?
No brainer. Coronaries.
Coronaries. Very stressful situation for you. A STEMI with a cardiogenic shock or a stable left main bifurcation with an eruptive nodule leading IVL to the both arms?
Neither.
Neither is a stressful situation?
No.
Great.
You have to rely on your training. It's 1,000 hours. You have to just focus on what you're doing. It's like anything. It's like coaching. So if I was trying to coach you how to play soccer, I would give you the rules and I'd send you off to practice it. It's the same with any coronary procedure. You got to know your equipment. You got to know what you can do, what you can't do. And then you got to remain focused in terms of dealing with the patient, irrespective of whether it's an unstable condition or stable condition. And in fact, the person that is, you have to treat them all the same. And that comes with working hard at what you do, working with the team in the lab. Everybody's part of that team. And if you do that and you're off the team later, you have to ensure you get the best outcome for your patient.
Perfect. Medical therapy?
I actually wore a heart rate monitor for a week on call, and I've measured my heart rate doing different scenarios, and I do a lot of complex CTOs.
No change? No change. Perfect. That is how you should treat yourself. Medical therapy or angioplasty or PCI in a stable angina?
PCI, if you've got a clear indication with evidence of ischemia, PCI.
Okay. And a coffee or tea?
Coffee.
Great. So fifth on trot for the coffee. The coffee is winning handsomely.
Coffee or beer?
I think that'll be a trickier question. So that's it for today, and we'll meet again with a new guest. Thank you.
Thank you.
Thank you.